We have looked at different types of pneumonia. We have used different risk stratification tools to assess patients' risk with pneumonia and aid in determining setting of treatment. And we have also looked at causative pathogens for different types of pneumonia. Now, given a patient with community-acquired pneumonia, design appropriate empiric therapy. Now, patients with community-acquired pneumonia can be divided into 4 groups. One group is the patients who can receive treatment as outpatient, and these are patients who have no risk factors for drug-resistant Streptococcus pneumoniae. So these are basically patients who are previously healthy and they don't have any risk factors for Streptococcus pneumoniae. The risk factors are listed on slide number 40. The second group is patients who can receive treatment as outpatients, but they have risk for drug-resistant Streptococcus pneumoniae. So these are patients who actually have comorbidities, or patients who have received antimicrobials within the previous 3 months. And of course, patients in group 1 who are actually in areas with more than 25% resistant rate of macrolide resistant Streptococcus pneumoniae, they should also come in this group. And the third group is patients who are actually admitted to the hospital but not in the ICU. And the fourth group are patients who are admitted to the admitted to the hospital and are in the ICU. So you can see here are the 4 groups and here are the recommendations. So for the group number 1, so these are patients who can be treated outpatient and do not have risk factors for drug-resistant Streptococcus pneumoniae. So the guideline, the IDSA guideline actually recommends as first line to give them a macrolide. So azithromycin is the number 1 recommendation for these patients. Now, alternatively, if someone could not tolerate azithromycin, doxycycline becomes the alternative recommendation. Now, if the patient is in group 2, meaning that they are at risk of having drug-resistant Streptococcus pneumoniae, because drug-resistant Streptococcus pneumoniae will be resistant to azithromycin or doxycycline, it's recommended to use a respiratory fluoroquinolone. So remember, respiratory fluoroquinolone is either levofloxacin or moxifloxacin, but not ciprofloxacin. Alternatively, you can use a combination of a macrolide and a beta-lactam. So either azithromycin plus amoxicillin or azithromycin plus amoxicillin clavulanic acid would actually take care of it. And the reason we need to add a macrolide to beta-lactam is because beta-lactams do not have activity against atypical organisms. Whereas if you use a respiratory fluoroquinolone monotherapy, levofloxacin, for example, they are active against atypical organisms as well as active against drug-resistant Streptococcus pneumoniae. Now, if someone could not tolerate macrolides, alternatively, doxycycline could replace the macrolide and in combination with beta-lactam. Now, in the third group, which these are patients who are sick enough to be admitted to the hospital but not in the ICU, whether they have risk factor for drug-resistant strep pneumo or not, they should be receiving treatment that covers drug-resistant strep pneumo, because these patients are severely, severe enough that their mortality rate is high. So we do not want to take a chance. So we make sure that we have activity for drug-resistant strep pneumo. So again, respiratory fluoroquinolone, a beta-lactam plus a macrolide, or beta-lactam plus a doxycycline. Now, another difference between between group B and group 2 and 3 is that because group 2 are treated as outpatient, basically they'll receive oral antibiotics. So pretty much all of these are oral. Versus in the ICU, because they're severely ill, we actually give them IV antibiotics. So now, instead of amoxicillin or amoxicillin clavulanic acid, which are only available as PO in the United States, now we give them ceftriaxone because it's available as IV only, in combination with azithromycin. And of course, the azithromycin will also be IV. Now, if you have the most severe case, which is the patients who are admitted to the ICU, Again, we do beta-lactam plus azithromycin. And now, because they are so sick that they're in the ICU and mortality rate is high, now we should also cover for Pseudomonas as well as for community-acquired MRSA. So what people tend to do is that they basically do beta-lactams that are active against Pseudomonas. So piperacillin tazobactam is active against Pseudomonas. Cefepime, and of course, meropenem is a carbapenem that's active against Pseudomonas. And then you add vancomycin or linezolid to the previous regimen to cover for MRSA. Now, of course, you will have to use your clinical judgment. Not everyone needs to be covered for Pseudomonas. So if you use the regimen at the top, so either a beta-lactam plus azithromycin, it may not necessarily cover Pseudomonas. So if you do ceftriaxone plus azithromycin, it doesn't cover Pseudomonas. So the regimens that are listed down here is only if you suspect Pseudomonas, which for the most part physicians do. If someone is sick enough to be in the ICU, physicians typically cover for Pseudomonas to make sure that we don't miss it. Because if you miss it, mortality rate will be high. And then you add vancomycin coverage on top of, whether you chose a combination from here or a combination from here, you just add vancomycin or linezolid to that regimen to add activity for MRSA.